past President and current Finance Secretary, Dr. Sarangdaran, to grace the dais. Today, the meeting will be presided over by Dr. Sarangdaran, our past President. We shall be commencing with the prayer for the day.
ഉംബർതരുത്തേനുമണിക്കശിവാഹി ഉൺകടലിൽ തേനമുദത്തുണർവൂറി ഇൻപരസത്തെ പരുകിപ്പലകാലും என்றனுயிர்காதரவுற்றருள்வாயே தம்பிதனக்காக வனத்தணைவோனே தந்தை வளத்தால் அருள்கை கனியோனே அன்பர் தமக்கான நிலை பொருளோனே ஐந்து கரத்தானை முகப் பெருமாளே பெருமாளே பெருமாளே.
I call upon Dr. Sarangdaran, our past President and current Finance Secretary, to deliver the welcome address and also share the current Central Council meeting points.
Thank you, Dr. Ramya. Respected dignitaries on the stage, executives from Billroth Hospital, and my dear family members of Iaoh and their family members, very good evening to all of you. So today I have been given the lovely job of welcoming to present the welcome address on behalf of our president. Our president has gone to Kolkata for a Central Council meeting yesterday, and so he is not able to come. And the other two vice presidents also are not able to come because of the rain. So the duty to deliver the welcome address has fallen on me, and it's really a great pleasure. First, it's my bounden duty to welcome the men and women of the day, Dr. A.N. Ramesh, Dr. Kiran Kumar, and Dr. Renuka. Uh, Really, the two topics are really, what to say, are very inquisitive and giving us a lot of imaginations. The micro beats of heart that is to be delivered by Dr. A.N. Ramesh, consultant interventional cardiologist from Billroth Hospital, and lifestyle embolizations, giving new life in varicose veins, prostate enlargement, knee osteoarthritis, and uterine fibroids. Very apt topics for all people like me. We are really, I'm really interested to listen to it. The lifestyle embolization, but by Dr. Kiran Kumar, consultant interventional radiologist from Billroth Hospital. And last but not the least, Dr. Renuka, medical officer Lucas TVS, Padi, Chennai. She's going to talk to us on periodic medical examination. I think she's going to brief us about some atypical cases. We are also very keen to listen to those cases. On behalf of all of you, I welcome all the speakers for this evening. Next, my welcome to the dignitaries, Madam and Sir. In spite of the thrill or suspense, whether we'll be able to have the program or not, we are able to run the show. On behalf of Iaoh Tamil Nadu, I welcome you all, welcome you both, and other executives also. And it's a great pleasure to invite my brothers and sisters of the Indian Association of Occupational Health, Tamil Nadu branch. This is part of my welcome address. Next, I would like to brief to you about the Central Council meeting that happened yesterday in Kolkata. I was also there in Kolkata. There are many, it was a, what to say, a very long drawn meeting starting at 2 o'clock and ending at 6:30. There are so many discussions that took place about administration, etc. Definitely a lot of job being to be thrust on the secretary's head. A lot of job he has to do now. Those details will come to us later. That may not be interesting to us. The nice point I want to share with you is our Indian Association of Occupational Health Tamil Nadu branch has been approved to conduct the All India Conference in 2025 for the 2025. It's very nice and interesting that all of us are clapping hands, but definitely our hard works has already begun. I will not say it is beginning, it's already begun. We have started planning so many things, myself and Dr. Sudha, we wanted to do so many things. Maybe next week we'll meet and then later we'll share about all those things. And the next good news I want to share with you is our Dr. Sundar, our past president of the branch, has been awarded the first ever Professor Arjun Das oration. So these are the two good news I wanted to share with you. And next, I wanted to briefly tell you about the BOHS activity that we are doing. And the slide, and the slide. இதிலே போட்டுக்குவேன். Two more camps are to be held. So far totally we have seen 2553 cases. It was well received in the Central Council meeting. Next slide. And the next one what we did, we coordinated with the Shankar Netralaya. Lovely, nice evening. Thank you.
Thank you, sir. I request the dignitaries to take their seats of dais. I call upon Dr. Sriram to chair today's sessions. Dr. Sriram is the Chief Medical Officer for TVS Lucas Padi. He is also a Central Council member as well as one of the senior most members of Iaoh. Over to Dr. Sriram.
Ladies and gentlemen, good evening. Welcome to all of you in spite of this cyclonic weather. So at the outset, big thanks to Iaoh TN as well as Billroth hospitals. We are going to have 3 wonderful CME program lectures. The first one, Dr. A.N. Ramesh, consultant cardiologist, interventional cardiologist, microbeats of heart. All of us are happy to listen to any beats, any rhythm. Probably he is going to talk on. Please come, sir. The rhythms of the heart. Followed by Dr. Kiran Kumar, interventional radiologist. And followed by the last speaker, Dr. Renuka Satish, about the real occupational health issues. So, a brief introduction about Dr. A.N. Ramesh, consultant cardiologist, Billroth Hospitals. He did his post-graduation in internal medicine from PIMS and DM cardiology from Chettinad, with extensive experience in diagnosis and treatment of various cardiovascular issues, diseases like CHD, MI, valvular diseases, etc. And he has done over 7,000 plus cath procedures. Soon he will cross 10,000 in the year to come, 2024 itself. We are eager to listen to you, sir.
Yes.
Over to N. Ramesh. Thank you.
Yes. I thank our MD Rajesh sir and Iaoh for giving me this wonderful opportunity to present this in cyclonic evening. And this topic is somewhat new for most of us, and this is one of the greatest invention in the field of cardiology. We all know that pacemaker is something which is huge, almost 4 into 5 centimeter machine, which has to be held below the left clavicle, and there will be a lead which is connected to the RV, and then it is totally a cumbersome to have a pacemaker. And so this microbeat is nothing but there is a small micro device which is invented by Medtronic. So far it is the only device which is US FDA approved. Even St. Jude's have nanotism, but they are yet to get the US FDA approval. But however, Medtronic has US FDA approval since 2016. And I'll start with the basics. We all know this. There's a what is AV block? There's a partial or complete interruption of impulse transmission from atria to the ventricles. And the most common, it is due to fibrosis or sclerosis of the conducting system, usually diagnosed by the ECG, Holter, and symptoms depending upon giddiness or syncopal attack. With the degree of block, the treatment varies, either conservative or the pacemakers. And as we all know, these are the various types of blocks. First degree, when the PR interval is more than 200 milliseconds. And second degree, when there is a prolonging of PR interval and there are missed bit, the second degree heart block. And third is complete heart block, where the atria and ventricle doesn't have any transmission. No impulse will be transmitted from the atrium and the ventricle. And the next slide is to compare the traditional pacemaker versus the leadless. It is implanted below the left upper chest wall, and the leads will be placed either in the RV apex or interventricular septum. And the average battery life is with 8 to 10 years will be the normal battery life of traditional pacemakers. Whereas leadless, it is the smallest and lightest device, and it doesn't require any pocket creation or any cutting and suturing. It is done through the right femoral vein and it hardly takes 30 minutes. There is no scar or no incision, no stitches required for this procedure. And as I said, these are the two devices, and the first bigger one is called nanotism, which is produced by the St. Jude Medical, which is yet to get the approval from US FDA, and the second one is called Micra. The difference between these two devices is that nanotism, it is just like a normal pacing lead, we can screw in, whereas Micra, you have 4 twines which has to be anchored to the muscle wall or trabeculae in the RV. And these are the comparisons between the nanotism and Micra. The normal length is 4 centimeter and wherein Micra it is only 2.5 centimeter, and volume is 1 and 0.8 in Micra. Weighing both the machines is 2 gram. As I said, in nanotism it is screw-in helix, whereas in Micra it is neonatal twines which can be anchored in the trabeculae. And facing mode we have both AV and single chamber facing. In nanotism it is mainly by the temperature, whereas in Micra it is by the accelerometer. The battery life is 9.8 years. In Micra we have 2 models. It is Micra AV and Micra VR, and the longest battery life is 10 years. And this is the basic thing to compare the Micra one, and this is the normal pacemaker, and this is where it has to be placed, normally in the right interventricular septum, and this is how it looks in the X-ray. Since our topic is mainly on Micra, since it is the only FDA approved machine, so I'll just compare the Micra AV is nothing but in normal pacemaker we have a single chamber and dual chamber, where in single chamber the lead is placed only in the RV, right ventricle, whereas in dual chamber the lead will be in RV and right atria. So Micra AV is nothing but it acts as a dual chamber, whereas Micra VR it acts as a single chamber, and the mass is and the weight of the Micra device is almost same, and the volume is also 0.8, and the electrode spacing, since it is a dual chamber, it is the electrode spacing is 18 mm. The battery longevity is almost 10 to 12 years in both, and they have a programmer which is similar in both, and as it is already said, it is mainly by accelerometer based on the rate response it works, and it is MRI compatible, and it can be capture management can be done through the remote monitoring also. And in both the system, it is the neonatal twines which is used for the anchoring in the RV. And this is the device. When you see this, the upper part is for the retrieval. When the position is not proper, by using this, we can retrieve the device and then reposition it. And you can see in the small device, which is almost a 1.8 centimeter, you can see there is an anode and there is a cathode. The spacing between these two electrode is only 18 mm. So it can actually act as a dual chamber pacemaker. And this is the twines. You can see normally there will be 4 twines. If 2 or more is anchoring, it is sufficient enough to stay and fix at the stable position. And this is the entire device, how it is used. There is a lock system, and the sheath will be almost 7 to 9 French. And this is how through the right femoral vein, we go across the IVC, and through the tricuspid valve, you do a clockwise rotation, and then there's a gooseneck deformity will be formed here. I'll show you the videos how it is done. And it is normally placed at the interventricular septum so that there is no dyssynchrony between the right and left. So it is almost equivalent to a CRT. The synchronization can be maintained. And this is what we have the evidence for the AV. So total only 40 patients were included in this trial. It is a marvel trial. And if you see that AV sensing is almost 94.3%, which is much higher than the traditional one. And in Micra VR, They have a data of almost 726 patients, and in this, almost 96 had no major complications. There is zero dislodgement, and there is a low revision rate, and they have been followed for 12 years, and the estimated longevity of the battery life is almost 12.1 years. The real load, the success rate is almost 99%, and complication is, normally in this complication we expect is either dislodgement or the pericardial effusion, and it is almost like 0.5%. Only 4 cases have been developed pericardial effusion or cardiac tamponade. And this is the complication rate with the various registries they have. And if you see at the MICRA, it is almost only 4 patients, 4% of the population. And the rate of pericardial effusion in case of MICRA, it is only 1.5 or 0.6%. Next, we'll be going to the case which we have done in Billroth, Arepuram. He is a 73-year-old gentleman. He is a poet, and both his daughters are in US. So he came with the complaints of syncope. So initially he is a retired government employee, so thought we will do a traditional pacemaker. However, since the financially they were strong, and we told them and explained the benefits of MICRA, and because the procedure time and discharge care will be very minimal in case of MICRA. I spoke to the doctors in US. They even took 2 days time, and they gave a nod to go for the procedure. His initial ECG showed a 2:1 intermittent 2:1 AV block, and echo was normal. His CAG, he had a single vessel disease, but it was borderline disease, so we thought we can manage medically for the coronary artery disease. And since it is an intermittent ECG, when we planned for the procedure, the morning 7 o'clock, we normally take a early morning ECG before the procedure. Surprisingly, it was a normal ECG when we took at 7 o'clock when doing. So it was confirmed after shifting to the ICU with the monitor. You can see there is a 2:1 block, and this is the admission ECG, where you can clearly see there is a 2:1 block. And this is the procedure through, normally we'll keep a temporary pacemaker for a backup, and through the right femoral vein, you can see this is a long 7 to 9 French sheath, and within the sheath you can see the MICRA device, which is just moving from the sheath, and we can make an angulation, acute bend, so that it can transpass the tricuspid valve. This temporary, the pacemaker will guide you so that you can identify the tricuspid valve where it can normally causes the RA and RV. And once it is beyond tricuspid valve, you try to rotate and fix, and it makes a gooseneck deformity like how we are seeing now, so that it just fixes in the septum. Once the position is proper, and we check it in 2 different views. So as you see here, once the position is okay, we are removing the temporary pacemaker. And once position is, after twining is implanted, this is how it anchors, and you don't need any support. And on table, we used to do a screening echo. If there is no pericardial effusion, it is very unlikely to develop effusion or tamponade after that. So we generally observe half an hour or 1 hour in the ICU, then shift to the ward. Since the right femoral vein puncture is almost 7 to 9 French diameter, so only for the femoral vein access site, we tend to keep them in the hospital, or else it is a daycare procedure only. You can just admit in the morning, do the procedure, we can discharge. We have a vascular closure device. In case if you do it, the vascular closure device is closed, then you can even discharge on the same day. We call them on the 3rd day of the procedure to check the parameters of MICRA lead. And this is the post micra ECG, and you can see there's a very good A sensing here with a rate of 70. And as I said, this is the twine which used to anchor in the right ventricle. There'll be normally 4 twines will be there, and if any 2 or 3 is anchoring well, it is good enough to hold the device for a longer time. And these are the knowns. We know that there's a high rate of implant success, and there is a stable, since it is attached to the trabeculum, there is a stable electrical parameters including threshold at a second 2-year follow-up. There's a small increase in pericardial effusion or tamponade, and comparable to the acute complication rate, the procedure. And unknown known is there's a lower risk of device infection. The long-term electrical performance is good. As in traditional, we don't keep the lead will not be across the tricuspid valve, so there will be it will avoid the tricuspid registration and lead induced or due to RV cardiomyopathy due to dyssynchrony, and it is a cost effectiveness is there. And what we don't know is how many device has been recalled or malfunctioning has been not known. And there are cases where you can implant up to 3 micra leads in the same chamber. So after only till now the case report is only up to 3 devices has been implanted in RV. Thank you.
Technology is advancing so much, and also the skills of the physician are parallelly increasing and improving very rapidly. So, if you have any questions, please.
Is this innovation of the original pacemaker, or how is it? I mean,
see, the device will be like the battery size, and it will be normal like a capsule size, which is almost only a 2 centimeter. And in the 2 centimeter, it has both anode and cathode and a battery. Since the device is very close approximate to the myocardium, the amount of energy required is very less. Normally, the threshold will be 700 in case of traditional pacemaker, whereas in case in micra it is only 0.2, which means the energy required and the battery longevity and stability is almost very good with the micra pacemakers.
So the take-home point is, in future, instead of the conventional pacemaker, we can go in for this pacemaker.
Yes, only the cost will be a little high.
Sir, good evening.
See, you have a single chamber will be 9 lakhs, and dual chamber will be 12 lakhs. What about the conventional? Will cost you 3.5 lakhs.
So you said in certain cases 3 devices would be stationed. What would be those cases, and is it required? Because in conventional, I have heard that only 1 pacemaker we would keep, or
No.
how does it work?
See, in conventional, we upgrade the device. So if it is a single chamber, they upgrade it once. Normally, the LV dysfunction will set in when there is a pacemaker is there in the patient. If there is a LV dysfunction, there will be widening of QRS, for which CRT, cardiac resynchronization therapy, is used. So that there will be a RV lead same lead can be used. There is a RA lead and there is a coronary sinus lead, which reduces the QRS duration and make the heart pump synchronously. Likewise with this, that was a question, no, for you? Or
Yes, sir. What would be the other conditions? Would the micra be 3 micras? Would you be putting it in during these conditions?
no,
I'm
micras is totally different. See, if the battery life is over, we'll try to, the lead, we don't generally remove it, since it will be fibrosed after so many years. So they very rarely remove the lead, because it has to be like, they'll tear, sometimes they can perforate, and the bleeding will be very high, since it's a venous bleed. So they generally don't take out the old pacemakers. With the same lead, we put a micra in the septal area and just come out.
Thank you, sir.
Left clavicle or right clavicle? Through the subclavian vein, we just go through.
So the cost is, though it is 2 to 3 times higher than the conventional one, it's really useful.
See, this patient just traveled after 1 week to US.
Sir, you said this is a 73-year-old man. Was angiogram done or not?
Angiogram done. It showed a 60% LED lesion. He didn't have any pain, so we thought we'll manage with the medicines.
And the last question. In olden days, they used to say the conventional this one, pacemaker. After the death, they are planning to, cremation, if it is not burial, it is on fire. So they need to remove it, they used to say.
It will normally,
Sometimes it may blast.
it will blast, but no one will be near the fire. See, normally we remove it. I have removed when. See, we can remove some.
Problem with this, such problem.
No. See, pacemaker is duration of the battery life. Okay, and
From sentimental value, even the dead body blasts.
we remove. Nothing will happen. See, after death we can remove. Just make an incision over the machine, and with the screw you can unscrew and take out the machine alone and suture it.
Any more questions, please?
In fact, you can even reuse it since the battery life is working it.
How many have you done here?
Micro in Chennai, it is almost more than 250 we have done. In our center, it is 12 cases we have done.
Thank you very much, sir.
Thank you.
Thank you, sir.
Friends, next 20-25 minutes we will be listening to Dr. Kiran Kumar, consultant interventional radiologist. His senior colleague, Dr. Shekhar, was my good friend. Now Kiran became my good friend. I never knew that you can do so much with embolization. In the invitation card itself, they have mentioned not only for varicose veins, prostate, fibroids, and so on. So, Kiran had his he studied from Coimbatore PSG institution and then did the higher studies in radiology from Billroth Hospital as well as Apollo Main Hospital. And he has several publications and did several personal projects to his credit. So we are eager to listen to Dr. Kiran Kumar, interventional radiologist, for the next 20 minutes. Thank you, sir.
Good evening, everyone. On a day with bad weather, hopefully this will serve as sufficient cause for celebration. So thank you to Iaoh and Billroth Hospitals and our MD and our management team for this opportunity. So today I'm going to talk about lifestyle embolizations, which are new developments in the treatment of varicose veins, prostate enlargement, knee osteoarthritis, and also uterine fibroids. So I am Dr. Kiran and I am a consultant here, and the first question that you will ask is, one second, some technical difficulties. Okay. So the first question, yeah. Okay. So the first question that you will ask is, who is an interventional radiologist? You might have heard of interventional cardiologists, but interventional radiologists, we are the newest branch of medicine. So the surgeries have been being done for the last 500 600 years, but angioplasties and stent embolizations have been done only since 1964, when Charles' daughter, who is our forefather, who started it. So we intervene with problems under radiology guidance using X-rays, ultrasound and CT scans. So the good thing about us is that we don't know surgery. The best thing about us is that we are always minimally invasive and we don't know how to handle a scalpel. And in a sense, we are kind of the engineers of the medical world who don't know how to cut. So in a way, we are also, like I always tell my patients, we are plumbers of the medical world. And we don't know how to turn off the heart also. So you can't do that with the plumbing system in the body. So, and why should you choose interventional radiology as a interventional radiology procedures as a treatment option? This is because cosmetically there are no scars at all. We don't know how to cut, and the majority of the procedures are daycare procedures, and everything, most of our procedures, maybe 90% of our procedures are under local anesthesia. And on the day of procedure, you will be undergoing the procedure, and next day you can walk off to the hospital. And there is an extremely low infection and a complication risk, and mostly due to the reduced hospital stay, there is a lower cost. On the right side, you can see that we play around with needles and also catheters. These are the usual things that we use in our day-to-day life. So what procedures do we offer? Do we offer only these 4 procedures? Absolutely not. We offer almost 90 plus procedures. So the thing is, usually I play around with the brain, the lung, the liver, spleen, kidneys, pancreas, anything other than the heart, we usually play with that. On the right side of the screen, you can see this is a vertebral artery aneurysm in the brain, which had already bled and we had embolized it. In the left side image, you can see that a large bulb-like projection is there. That is the aneurysm that had bled. But on the right side, you can see this after coiling, the aneurysm is completely excluded from the circulation with normal flow beyond it. So some newer procedures are there which are coming up. The thing is, usually before 2017 or 2015, we used to work only in the emergency setting. So we used to do embolizations only. When a patient is bleeding, acutely bleeding, we used to go in and embolize it. But then newer procedures have come up where for normal like osteoarthritis and for benign prostatic hypertrophy, new procedures have been developed, and this is what I want to talk to you about. And this is another case where the entire lung was bleeding due to post-TB sequelae. You can see that the right lung is almost completely, near completely replaced by bronchiectasis. You can also see the snake-like appearance of the enlarged bronchial artery. In the other image, post-embolization, you can see that the abnormal vascularity is almost completely stopped. This is another angioplasty that we had done recently in the common femoral artery. In the common femoral artery, only a POBA helped, that is plain old balloon angioplasty, and the patient went home safely. So simply put, to get to here on a metro from Shenoy Nagar, I will take the Shenoy Nagar metro, the green line, and I will get down at Vadapalani. So for me, this is the metro system of the body. So I will either follow the blue line or the red line, get to where I want to and do what I want. So the first thing that I want to talk to you about is varicose veins. Varicose veins are superficial veins in the subcutaneous tissue that become enlarged on standing. So these are a common manifestation of underlying chronic venous disease. So most patients will have an occupation that requires prolonged standing, a history of injury to the lower extremity, age, obesity, family history, previous pregnancy, smoking, all these are established risk factors. So usual symptoms are leg heaviness, foot swelling, and pain, discoloration, and when it goes on and on, it can lead to ulceration also. So the problem is basically chronic venous insufficiency. When the valves are incompetent, there can be abnormal movement and stasis within the veins of the leg and the foot. So this can lead to venous wall remodeling and secondary inflammation. Goes on and on, it can lead to ulceration also. So this is the classification where the CEAP classification, C stands for the clinical. So either it can be C1, which is the spider veins that we see in the early stages, C2, which is the proper varicose veins, C3, which is a swollen leg, C4 can be skin damage, C5 is a healed venous ulcer, and C6 is an open venous ulcer. So the first thing that you will ask for in varicose veins is a venous Doppler. So in the venous Doppler, we check for the valve competence. When there is significant reverse or reflux lasting for more than 0.5 seconds, then we term that vein as incompetent and it is prone to develop varicose veins. We do this as a significant thing because it is also very important for post-treatment follow-up. So the first thing about varicose vein management is lifestyle management. You will have to stop standing for a long time. You will have to stop alcohol and drinking. It's alcohol. Alcohol is the same as drinking. Sorry, it's smoking and drinking. And the second thing, you can graduate to compression stockings. So the second thing that you will try is compression stockings. But the thing is, compression stockings, wearing it for a long time is a very cumbersome procedure. So when the patient is fit to undergo surgery, we usually start with surgery rather than compression stockings. So the next thing about in the varicose veins treatment is surgical vein stripping. This usually used to be performed, but now it's not performed except in government hospitals. It is a very cheap procedure, but at the same time there is a lot of scarring. The next thing is injection sclerotherapy, where you put some sclerosant into the veins and try to collapse the vein. The problem here becomes the vein only, and when you collapse the vein, almost all the problems stop. The current gold standard is radiofrequency and laser ablation. Laser ablation works better than radiofrequency in my limited experience. So here we put a laser fiber through the vein and burn the vein slowly from top to bottom. So this is the laser ablation procedure. You can see that we are putting some local anesthesia along the vein, along and around the vein. And the image shows a scalpel, but I don't use it. I just use a needle and I get inside, put a sheath inside. Then I introduce a laser microfiber under ultrasound guidance. The laser microfiber goes from the leg region up to the thigh, and using heat from the laser, we ablate the entire vein, pulling it out slowly. 1 to 2 mm per second is the prescribed criteria. And then after a while, we take everything out and the vein remains ablated. The rest of the blood, the normal blood flow, will be taken care of by the deep venous system and not the superficial venous system from now on. After this, even if there are small veins remaining, we will do foam sclerotherapy for this. And after this procedure, we will make the patient wear compression stockings for at least 2 weeks, such that the vein becomes completely sclerosed. So the advantages of this procedure are these. It's a very short procedure, 30 minutes will be the table time. You don't need to make an incision at all. It's a daycare procedure. The patient can walk home on the same day. The patient can walk to work on the next day. There is absolutely no post-procedure pain. The occlusion rates are excellent, the 88 to 100% range, and long-term efficacy is almost the same as surgery. It's extremely cost-effective. The only problem is that 1 to 3% of individuals, that is like if you treat 100 people, one person may have superficial vein infection and or minor burns. So the problems that varicose veins can cause are cramps, discoloration, pain, itching, ulcers and swelling. But the thing is, when you remove that with this laser ablation, it is easily treatable. So early treatment gives a better response. The first step is always lifestyle modification. Laser ablation is safe and effective. Patients can walk home on the same day. Coming to our second issue for today, prostate problems. Why does it happen? Usually prostate enlargement can be due to benign prostatic hyperplasia. So the benign prostatic hyperplasia occurs due to this. You can see the image there. The prostate is like a heart-shaped organ just below the bladder. In the normal prostate, you can see that urine has a way to come out. But in the abnormal prostate, the enlarged heart-shaped gland is seen compressing the urethra, and thus there is no significant flow of urine. So BPH is highly prevalent, affecting up to 50% of males at the age of 50 years. So take a person on the road 50 years, there is a 50% chance that he has BPH. And 90% of males above 80 years will have BPH. Symptomatic BPH needing treatment is there in 50% of these patients. So pick a person on the road, a male patient, 50 years old, he will 25% have a chance of having BPH which needs symptomatic treatment. So BPH causes two types of symptoms, which are basically storage symptoms and also voiding symptoms, but that is an old concept. Nowadays it's just symptoms as a whole, so they are no fun. So it manifests as increased frequency, urgency, and also multiple times of getting up during night time, so to pass urine, and this actually destroys the patient's life. So the treatment is something that, you know, again it starts by lifestyle modification. So to the patient, you tell everything that as a doctor that you can't do. You can't eat a healthy diet. So you also can't avoid high fat food. You can't wear comfortable clothes. You have to be in formals all the time. You can't make cardio a priority. So you may, and also you should manage your stress level also. Of course, you can't do that. So you tell the patient to do all these, but you don't do all that. So the first thing will be lifestyle modifications. The second, usually BPH responds a little bit to lifestyle modification, but mostly it doesn't. The next thing is medical management. We have three amazing group of drugs to combat this BPH, and usually nowadays urology practice of BPH is mostly medical rather than surgical. So three things, we do alphazocin and its group of drugs. Then we have this tadalafil and PDE5 inhibitors. Then we also have 5-alpha reductase, finasteride groups of drugs. So the next thing, if the patient is refractory to medical treatment, then surgery is indicated. So the surgical approaches are a few, TURP that are done in India are a few. So TURP, laser TURP, TUIP and Urolift. So you can see this is the normal prostate which is here, which is the heart-shaped gland, and here it is the enlarged prostate compressing the urethra. Post TURP, they will go in with the resectoscope through the urethra, core out these sides of the prostate gland. So they will core out these sides of the prostate gland either using a resectoscope or using a laser. So this is how TURP works. And the next procedure that I want to talk about is radically new, and it's called prostate artery embolization. Lots of centers in abroad are doing it, but it's not yet fully taken over in India. This is how it works. So during the treatment, we approach the arteries that are supplying the prostate, put some embolic material there, occlude the arteries coming to the prostate, and then after treatment, the prostate slowly shrinks down. I'll show you a video also of how we do it. So prostatic artery embolization is an alternative to surgical options with a prostate size of more than 30 cc without an upper size limit. So we have treated prostates which are also 100 grams also. So patients who have comorbidities or unfit for surgery were the first patients who we did this procedure for. But then finally, nowadays also, I didn't tell you about one big problem with TURP. TURP causes retrograde ejaculation. There can also be urinary incontinence, and mostly there is erectile dysfunction. Most patients cannot tolerate this, especially in the younger age group. So patients on anticoagulant and antiplatelet therapy, these are also patients who can undergo this prostate artery embolization. The risk of developing all this abnormal ejaculatory symptoms and erectile dysfunction and incontinence in prostate artery embolization is absolutely zero. So how does it work? We put alcohol there. So basically not a regular grade alcohol. We use PVA particles, which are polyvinyl alcohol particles. You can see the particles here like a powder. And when suspended into a contrast solution, they look like this. So who will benefit from PAE? Patients with moderate to severe lower urinary tract symptoms, those who have significant post-void residue, patients who have already undergone failed medical treatment, urinary retention patients, patients who wish to preserve erectile or ejaculatory function, and patients with hematuria, and patients who are deemed to be not surgical candidates. So suppose EF is 15 to 20%, then you can't take for TURP, then this is a good thing. And patients refusing surgery are also benefiting from PAE. So the pre-procedure workup will always include a urologist consult, an IPSS, which is the prostate symptom scoring, a baseline uroflowmetry, the patient's quality of life in general, sexual function status of the patient, prostate volume, PSA and PVR. Then you will also, because these prostatic arteries are very small, they are almost only 1 to 2 mm in diameter. So you will need a CT angiogram to look for the origin of the prostate arteries. The procedure is simple. It's a day care procedure. You can walk in for the procedure and walk out of the procedure just like that. We either take a radial puncture or a femoral puncture, go on to the prostate artery. You can see that there are arteries supplying the prostate here. We put a microcatheter inside the artery, make sure we are in the prostate artery by doing a cone beam CT that is nicely available at our cath lab, and then we embolize the proximal first, occlude the artery proximally first, then go distally and also embolize. So it's called the perfected technique. It works wonders in prostate artery embolization. So over a period of time, the prostate slowly settles down in size. Maybe 1 to 2 weeks it starts. In 6 months, the effect is the maximum, and then urine can come out freely. So this is a case. You can see the small prostatic artery which is coming medially. This is an internal iliac angiogram. And this is a microcatheter run through the prostate artery. You can see one half of the prostate actually being completely outlined. It is actually significantly hypervascular. These many arteries should not be there, and these corkscrew type arteries are definitely abnormal. And here we are embolizing the proximal first. Actually, the embolization is also the contrast. You can see the contrast going in, that is the embolic material also. The vascularity is coming down. And this is us going a little bit distal and also embolizing. So proximal first and then distal. You can see some areas of contrast material still there. And this is the post-embolization run, which you can see now. You can see that the entire prostate is completely embolized. It has no blood supply from the prostatic artery. The natural question that a patient will ask is, won't the prostate die? The prostate also has multiple collateral supplies, especially from the rectum, the urethral vessels, and also the bladder neck. So it does not die. It takes the only prostatic artery supply is cut off, so it only reduces in size. Post procedure, the clinical follow-up is at 3, 6 and 12 months. Usually 1 to 2 weeks after the procedure, the patient can be catheter free if they are catheter dependent. You can also do an MRI and ultrasound to look for the difference in the volume. So complications are very few. Any embolization, you can expect some nausea, vomiting and pelvic pain also. It can be managed with one Acton over only. And urinary infection, self-contained hematuria and acute urinary retention can occur in few patients. So take home points, a urology evaluation and a uroflowmetry is must. It's a new minimally invasive alternative. It needs meticulous workup basically. The thing is urological and radiological coordination should be there. It is suited for younger sexually active patients and patients who are concerned about the same. The thing is most patients, even 70-year-olds now, when we counsel for PAE, they are mentally young. So the thing is most people are willing to do PAE. Coming to the next topic, which is knee joint osteoarthritis. So osteoarthritis, like we all know, the thing is it is a degenerative joint disease. When the cartilage of the knees are gone, the bones start rubbing against each other and then it causes chronic pain and disability. So the thing is again like BPH, it occurs in upwards of 50% of individuals during their lifetime. So as the population continues to age, and nowadays we have a lot of obese patients also, so this leads to increasing cost of surgical intervention for knee OA. How does it work? So the pathophysiology of osteoarthritis is that when both the cartilage deficient areas of the bone are rubbing against each other, they release inflammatory cytokines. These cytokines promote neoangiogenesis. They promote new vessel formation, and these vessels also make a highway for the extra cytokines to come in also. So the problem with the entire osteoarthritis becomes a plumber problem. So more vessels, more inflammation. So embolize it, less vessels, less inflammation. This is the target for genicular artery embolization. The symptoms of osteoarthritis can be pain and stiffness only. So we grade it from 0 to 4 using the Kellegren and Lawrence system. MRI can also be used to see the soft tissue damage. Treatment is again lifestyle modification, exercise, weight loss and biomechanical aids. The next thing would be NSAIDs. The next thing would be corticosteroid or hyaluronic acid injections, which are short-term relief, and the last thing would be a TKR, where we replace the entire joint. The thing is, GAE is a experimental procedure. I have done only one at Apollo, so it is a minimally invasive option that can complement the current protocol just before doing the TKR. So it can delay TKR by around 10 years or so. So this is the genicular artery embolization, where the medial joint, the thing is the knee joint is made in such a way that the medial joint compartment receives at least 1.8 times the force, the stress of the lateral joint compartment. So the thing is, at least 5 geniculate arteries are supplying the knee. So when we embolize the medial only, you can have significant pain relief. You can see this is the medial condyle of the femoral condyle of the patient being outlined by extensive hypervascular networks. You can see it here in the image on the left side. This is the main geniculate artery, medial geniculate artery, and you can see extensive extravascular supply and a vascular blush also, which should not be there. This happens due to extensive joint inflammation of the joint capsule. And here you can see post-embolization with imipenem and cilastatin solution that the vascularity has significantly come down. So which patients will benefit from GAE? So chronic knee pain which is refractory to conventional therapies for at least 3 months, spontaneous pain including nighttime pain and rest pain, local tenderness during physical examination especially at the medial and lateral condyles and also at the anterior aspect along the synovium and periosteum, pain that occurs while climbing the stairs. The thing is, pain while walking on flat ground should be evaluated carefully because the problem may be too extensive for GAE to conquer. They may need a TKR. So procedure details are very simple. We take an antegrade femoral puncture at the groin, go down into the knee, identify these arteries which are supplying the knee. Usually because of osteoarthritis they become bigger, and embolization with imipenem, cilastatin sodium and contrast solution. And as long as there is stasis, you take it as an endpoint and finish it there. If there are 5 arteries, we can embolize 3. So complications after GAE are very, very transient. It's only a walk-in daycare procedure, and there can be transient cutaneous erythema only, and there can also be a little transient fever. Take-home points. It's a degenerative joint disease, osteoarthritis with neovascularization. The problem is new vessels. In the past decade, preliminary studies have been done across various other countries and the safety and efficacy has been proved. So it's a daycare procedure with a definitive role in mild to moderate knee osteoarthritis which is refractory to conservative treatment. And the last topic for the day is uterine fibroids. Uterine fibroids are a very, very common problem. So these are the most common benign pelvic tumors in women with the prevalence ranging from 4.5 to 68% depending on the study population. So in the Indian population it's around 10 to 20%. If you take Africans it's like 50 to 70%, which means that if you take 2 women on the road, 1% will have uterine fibroids. And around 25 to 50% of these patients are symptomatic with bleeding or pelvic pain. So the thing is, you can see the types of fibroids here. There are four types of fibroids. You can see that there is a submucosal fibroid which is projecting into the endometrial cavity. There is an intramural fibroid which is within the wall only. There is a subserosal fibroid without a stalk, and there is also a subserosal fibroid with a pedunculated stalk. So all these are the types of fibroids, and some of them can be half in half there. So partially submucosal, partially intramural can also occur. So 30% of these patients can resort to invasive surgical therapies which can be either myomectomy or if the patient has completed their family, hysterectomy. So common symptoms include pain, bleeding, painful periods and pelvic mass-like symptoms. Some fibroids can be even 20 centimeters where they look like almost a pregnant woman. So what is uterine artery embolization? It is a minimally invasive procedure for relieving fibroid related symptoms. Again, it's a daycare or an OP procedure, and the thing is you can do it with only local anesthesia, but the problem with uterine artery embolization is that post the procedure for 1 day the patient will have a little bit of pain. So it is indicated in patients with completed families only. Right now studies are going on fertility post uterine artery embolization, but for now if patients want to get conceived post a procedure for fibroid, then myomectomy makes the most sense. Of course, it is still under study. So the contraindications for uterine artery embolization are only 2. It doesn't depend on the number of fibroids, the morphology of the fibroids, the symptom of the patient, nothing. It doesn't depend on anything like that. The only contraindications are 2, viable pregnancy and pelvic infection. Once you rule out both of these, you are good to go ahead and embolize. So surgery versus embolization, this question is always there because naturally OG people will be against uterine artery embolization, but a meta-analysis of surgical methods, this procedure has been there since 1996, and there is uterine artery embolizations show fewer major complications. The ME trial, which is like a 10-year outcomes of uterine artery embolization and myomectomy, showed that UAE was an acceptable alternative to surgical treatment in women who wish to preserve the uterus. Surgery or that is myomectomy is best suited for females who are planning for pregnancy. So pre-procedure workup, we always get an ultrasound done and an MRI done just to localize the fibroids. You can see that this is the normal uterus. This is the endometrial lining. This is the junctional zone. This is the myometrium. And you can see this is the body of the uterus. This is the fundus, the body of the uterus. This is the cervix, and you can see the vagina also. And this is the bladder anteriorly. And here you can see that there are multiple intramural fibroids distorting the myometrium within. So you can see this is one fibroid, another fibroid, another fibroid, another fibroid, and another, the largest fibroid is here. You can see it completely distorting the myometrium, and you can see that the cervix is being pushed also here, and the bladder is also being pushed secondary to the mass effect. This is the procedure. It's a daycare procedure. You can see it being done. Sorry. This is a internal iliac artery run within the uterine artery. You can see this huge fibroid being outlined. The whole of the area is the uterine fibroid. You can see it wholly being outlined. And post embolization, you can see that the hypervascularity has completely come down. There is no vascularity within the fibroid at all. Because of the loss of the fibroid vascularity, it will come down in size over time. This is a right-sided injection. You can see that the rest of the fibroid is being supplied by the right uterine artery also. And after embolization, you can see that even that is not there. So the entire fibroid has completely lost its vascular supply. Again, the question is, if you have completely stopped the uterine artery supply to everything, won't the uterus go in for necrosis? Again, the answer remains the same. The uterus has multiple blood supplies from the collaterals. It has broad ligament areas which collateralize. There can also be ovarian collaterals, cervical collaterals, and also vaginal collaterals which can supply the uterus, the normal uterus and not the fibroids. So that way, uterine artery embolization is like super selectively targeting the fibroids. And for post-procedural pain, we usually start the patient along with epidural analgesia. The thing is, this pain, everybody's pain threshold varies. So the thing is, some people can tolerate pain with only NSAIDs, but some people ask for pain relief more. So we start off with epidural analgesia and taper it down. So NSAIDs and opioids, and also there is something called as a superior hypogastric nerve block. Just anterior to the L5 vertebra, we can block the superior hypogastric nervous plexus there and stop the pain also from where it starts. So the take home points for UAE are these. It is an effective treatment, it is proven, and it's a great treatment for uterine fibroid related symptoms. It is best suited for women who have completed families. Fertility post uterine artery embolization is still under study. Epidural analgesia for post procedural pain management is a gold standard right now. So you can see here, this is a pre and post image of one of our patients. You can see that they had a large fibroid in the anterior wall, near completely replacing the anterior wall. And post embolization, 6-month follow, there is nothing there. And here also, this is a contrast enhanced MR image. You can see that this fibroid is partially submucosal and partially intramural. It is nicely enhancing. And in the 6-month post follow, there is nothing there. So the thing is, uterine artery embolization works excellently. And with that, I'll bring my talk to a close. Thank you.
Thank you very much for a wonderful, very interesting presentation. We never knew that interventional radiologists can almost replace surgeons.
Then, because you could not even tie the uterine arteries, then we could embolize it though.
Probably you can help malignant tumors, solid organs.
We usually do that also, sir. Nowadays, transarterial chemoembolization is coming up in a big way. So we can completely stop the blood vessel from supplying the mass or either. Even before surgery, we recently did it for a renal tumor, where the patient had a renal tumor completely replacing the left kidney. We stopped the blood supply to the left kidney fully, and then they took out the tumor, almost bloodless procedure.
And massive spleens before splenectomy, etc.
Yes, sir, true. That can also be done.
As he encroached upon the question answers time, there is not much of time for questions. If you want to ask any specific questions, anybody interested in asking? Or else you want to put it to the dinner time? Right, sir. Thank you very much.
Thank you.
So I invite the last speaker of the day, Dr. Renuka Satish from Lucas TVS Padi. Dr. Renuka has over 27 years of experience in the medical field, mostly OH, occupational health, and she is awarded AFIH from Ramachandra Institution. Basically, Bachelor of Medicine and Surgery from Stanley Hospital, Stanley Medical College, and she has done MSc in clinical embryology, especially in Lucas TVS. Right now, she is taking care of all the women employees with special additional charge of girls' hostels, creche, the canteen, and several other responsibilities. And she has lot of OH work experience earlier in Hyundai Motors and Yamaha Motors, etc. With this brief introduction, she can start after this momentous presentation. Over to Ramya.
Thank you, sir. Sorry for the interruption. Due to time constraint, we are expecting Dr. Ramesh. He has another prior engagement. So we would like to call upon Dr. Kashi Vishwanathan, one of our senior consultants, to give away the memento to Dr. A.N. Ramesh. I call upon Dr. Kashi Vishwanathan, sir, to give away the memento to Dr. A.N. Ramesh. Thank you, sir. Over to you, Dr. Renuka.
Yeah. Good evening all, and I would like to thank Iaoh as well as our Billroth hospitals as well as our management for providing me this excellent opportunity to present regular cases like what we come across during our periodical medical examination. Periodical medical examination, which we do as medical officers, it's a part of a statutory for us, and we do it for our hazardous area workers. It is a regular routine, but apart from that, do we do anything? In our factory especially, we do the regular medical checkups on the annual basis for all the management workers and other people who are all in the non-hazardous areas. This is about a very interesting case which we encountered while we doing this periodical medical examination. And this is about Mr. S. Let us keep his name as Mr. S. And he is a 56-year-old employee. And he is working in a quality department. And he has got his 26 years of experience in this factory. He is an obese personality, height 170 meter and 89 kgs. And he is a known diabetic for past 5 years. He was on oral hypoglycemics. He is a dyslipidemic patient, as he was also obese. He was hypertensive as well as ISG patient. He was on regular medical treatment. Personal history: he is a non-vegetarian as well as non-alcoholic, non-smoker from his adolescence. He says that he has stopped smoking by 40 years of age. And going through the medical history, 2016 he had an episode of acute pancreatitis. He was treated symptomatically, and by 2017 he became dyslipidemic, and he had a bypass surgery for his ISD, and he is hypertensive also on regular treatment from 2020, diabetic from 2021, and he was non-insulin dependent. This is the treatment history which he had, like pantoprazole and atrostatins and blood thinners. He was on telmisartan and metoprolol. For diabetes, he was taking gliclazide and Javanamate. Annual medical examination for him was taken care by the diabetologist as well as the cardiologist. And we in the medical center, we have got the inbuilt laboratory, so we used to do the CBC and biochemistry as well as ECG every year. The findings as well as with the cardiologist and the diabetologist, it all was the same. And in our medical center, whichever investigation we have been doing for past 20 years, it all was the same. But what we found was in CBC findings, his hemoglobin was dropping from January 2018 to January 2023, from 13.5 to 10.9 slowly. We just thought this is of significant importance, and we asked them to do the stool examination for occult blood, and it turned out to be positive. From January to February, this stool examination was done, and then CT abdomen and UGA endoscopy was done by the gastroenterologist, and the findings were hypodense lesion in the right lobe of liver, and there was splenomegaly and para-aortic nodes in the CT abdomen. So the PET scan was suggested by the gastroenterologist, and we found it to be a neuroendocrine CA tail of pancreas with liver mets. He was referred to Adair Cancer Institute. Palliative surgery was suggested there. Radical antegrade modular pancreatosplenectomy along with liver metastatectomy. This was done in April. Histology revealed well-differentiated NET, neuroendocrine tumor. It was graded Ki67, 10% grade 2. So then he was recovering, and OHA was stopped. Injection Lantus, so he was on injection Lantus. And by another 3 weeks, he was undergoing vaccinations, influenza and pneumococcal vaccines. And subsequent follow-ups, he is taking octreotide acetate, 30 milligram depot injection every month, according to Adair Cancer Institute suggestion. And by 4 months, from April to August, he went well, the treatment was good, and he got the fitness from the Adair Cancer Institute, and he recovered, weight gain was good, about 82 kgs he is now, and he has joined his duty now. Diabetes was under control with insulin, on regular medication with hypertension and dyslipidemia. Now he is in regular follow-up for the recurrence, early detection of the recurrence. He hasn't got it now, like he is on regular follow-up. Just a simple glance about the pancreatic CA. The risk factors being the smoking, tobacco, alcohol, obesity, gallstones, cholelithiasis, diabetes mellitus, fatty diet, chronic pancreatitis, and chemical exposure, asbestos, pesticides, dyes, and petrochemicals. Family history and genetics. This person is working in quality, and he was not exposed to any industrial dyes or any chemicals or anything. But he has got this smoking, tobacco positive point, and obesity, diabetes mellitus, and 1 episode of acute pancreatitis. Pancreatic tumors, they can arise from the exocrine cells and the endocrine cells. Exocrine cells, mostly 90% of them are adenocarcinomas, and rest of them are non-adenocarcinomas. From endocrine cells, we know it is NETs. They may be functional or non-functional. Functional, they may become insulinomas, which is more common in the functional type, and 16 to 30% may be gastrinoma. Less than 10% are vasoactive intestinal polypeptinomas. 5% are somatostatinomas. Non-functional, mostly they cause the mass effects and malignant. This is the revised WHO classification, well differentiated and poorly differentiated NENs. This is based upon the nuclear mitotic index, mitotic activity, which is seen, and it is named as Ki67 index. NET grade 1 is less than 3 mitotic activity per 10 high power field, and grade 2, 3 to 20. This person, he falls in grade 2 category, less than 3 to 20 cells of mitotic activity per 10 high power field. More than 20 falls in the grade 3. It can be well differentiated or poorly differentiated. Conclusion, here comes the importance of the periodical medical examination for all. Like we can do the basic medical examination for all the workers, whoever it be, hazardous or non-hazardous area workers. This becomes significant not only in the hazardous area workers. It can help us to early detect the certain diseases which extends the quality lifetime of the workers who are all under our care. I would thank the management who supported a lot for this person by a period of another 4 months from the treatment period to the joining time. He was supported a lot from our management, and many more thanks for that person who took the small scope like hemoglobin was less, and then he went for the another investigation and subsequent investigations, and he got cured at last. Thank you. Thank you all.
Thank you very much for a very interesting case presentation, Dr. Renuka. And as we know, unless we keep our eyes and ears open, we can't pick up these things. See, anybody may have 10.5 hemoglobin, which is not very abnormal. But when you see the trend, when it is coming down from 13 to 10 in a short span of time, gradually, then you need to look for things like this, what she has done. Similarly, Dr. Mohan has picked up one chronic renal failure, CRF case, and that gentleman also in periodic medical examination. There was no other clue except a bit of tiredness. Now he has undergone cadaver transplant and he is doing very well. So this is the importance of, so there was a story, blind people touching an elephant and each one describing a part in a different way. Belly is different, legs are different, they thought it is pillars, ears are thought of something. So unless you know what it is, you anticipate, you expect, you look for it, you don't find it. As Madam mentioned, we even do periodic medical examination for casual labor also. There are 650 casual labor who cut the grass or who housekeeping people, etc. Including them, we take it up, not only for managers and officers. So wonderful presentation, Ma.
Thank
So
you,
any
sir.
questions, please?
Yes, sir.
It's, I mean, during our clinical exposure, we get a doubt, but all the time you will not get the answer. So you have to keep follow-up, and sometimes repeated investigations may be required. And sometimes if you don't get answer, so you have to take the help of other specialists, one specialist to another specialist. Which system is involved? Everything is really a clinical jargon and dilemma. We have to keep working on that. If you don't get answer, patient has to be in the loop line so that he will not go to the bad turns. It's nice. That one comment, but you nicely prepared the case. Congratulations.
Thank you, sir. Thank
You're
you so
welcome.
much.
Yeah.
Any other questions?
Good, Dr. Renuka. It is very nice you're emphasizing the importance of occupational health in an industry. My doubt is, you said he did not have any exposures to chemicals.
Yes, sir.
You said he is from the quality department.
Yes, sir.
What is his actually duty there? Quality in the sense?
Quality
Because in
is
my
the
company, the
managerial- Yes.
quality experts are definitely having exposure to chemicals.
Yes, sir.
So in your case, what was it?
He is in the managerial cadre. So he will be working in the office and he will be putting the data putting the
No,
data
right from the beginning has he been doing that, or to start
right
with he
from
was
the beginning, sir. Right from the beginning.
to
That's
start
what-
with whether he had any
Exposure.
quality work which had made him to be exposed to chemicals in the
No,
early
sir.
of his
Actually, he
career.
was working for 26 years and he was in the managerial cadre. That is the
Right from the day
beauty.
one.
Yes, sir.
That's good. Anyhow, congratulations.
Thank you, sir.
But he had all other risk factors she has shown, except chemical exposure and we don't know about genes, family and genes. Except that, all other risk factors he had. Any other questions? Yeah, back to Ramya, please. Thank you.
Actually, this question is directed to Dr. Kiran. Sir, in this case, would interventional radiology play any part? Would, instead of surgery, would that be this thing?
thing is, surgery would be curative in this case, which was performed. So the thing is, there are some newer trials which they inject something called PRRT, lutetium labeled peptides, into the liver to shrink the size of the metastasis only when it is inoperable, when both lobes are involved. In this case, only one lobe was involved, and that's why he could get away with a hepatectomy. No, sir, not as of yet. Yeah, we do have therapies for neuroendocrine tumor metastasis, but not for the primary tumor per se, in which surgery will be curative.
Thank you, sir. Thank you, Dr. Renuka. Thank you all speakers for your enlightening sessions. It has been a wonderful learning experience, especially for me, from Dr. Kiran as well as from Dr. Renuka and Dr. Ramesh, who was left due to prior engagements. Now, I'd like to call upon Dr. Sarangdaran, Finance Secretary, to present the memento to Dr. Kiran. Dr. Sarangdaran, please. I call upon Dr. Ashok to present the memento to Dr. Renuka. I call upon Dr. Sriram to present the memento to Dr. Valli, MS of Billroth Hospitals. I call upon Dr. Sailesh to present the memento to Dr. Gulam, Clinical Administrator, Billroth Hospitals. Thank you, sirs.
Madam, we personally thank you. And as I already discussed with you, we are waiting for your help for our conference next year.
Thank you all. I call upon our Secretary, Dr. Ashok, to present the vote of thanks.
Good evening, all. I thank honored everyone who has made their way here during the weather condition, even in spite of that, and make this evening a wonderful event. It was possible to have this wonderful session. Those who missed the session also had an opportunity to view the session to live relay. So it was wonderful. It was in fact very helpful for many of our fellow colleagues who have not been present today due to the weather conditions. And I take this opportunity to thank Billroth Hospitals to conduct this wonderful CME session on topics which are very new, very late, new to, in spite of knowing that the subject is very common, but the techniques which are being introduced in the recent times is very new. By the whatever is covered by Dr. Ramesh, who is not here right now, is totally a new topics which is for us an enlightenment. And Dr. Kiran Kumar, who has also contributed new topics in embolization, was also wonderful. And I also thank our fellow colleague Dr. Renuka, who had a different perspective of periodical medical checkup and identified a wonderful case of neuroendocrine tumor, and then has given a betterment to the worker who is not part of a regular hazardous operations exposed person, which was new to us actually. And I also thank the management of Billroth Hospitals again to have this arrangements done, and the hospitality by Green Park Hotel, and by our fellow coordinator event management, Marjishwara. I once again thank every one of you, sir. I thank, excuse me, I forgot to thank our chairperson, Dr. Sriram, from our senior member, and our MC, Dr. Ramya. Thanks again. Thank you, everyone. A group photo, please. Members, Billroth's team. Others can join the dinner.